CNA Infection Prevention Study. Welcome to the quiz. Question 1. Which segment of the nephron is the primary site for the regulation of calcium reabsorption under the influence of parathyroid hormone PTH? Option A. Proximal convoluted tubule PCT. Option B. Distal convoluted tubule DCT. Option C. Thin descending limb of the loop of Henle. Option D. Collecting duct. The answer is B. Calcium Ca reabsorption occurs along the nephron, but its fine regulation is hormonally controlled. About 70 is reabsorbed passively in the PCT paracellularly, following sodium and water. Another 20 is reabsorbed in the thick ascending limb TL via paracellular transport driven by the positive lumen voltage. However, the primary site of regulated reabsorption is the distal convoluted tubule DCT. Here, about 10 of filtered Ca is reabsorbed, but this portion is crucial for determining final urinary calcium excretion. Parathyroid hormone PTH, released in response to low blood calcium, acts directly on DCT cells. It increases the activity of apical calcium channels TRPV5 and basolateral calcium pumps/exchangers PMCA and CX, stimulating active transcellular calcium reabsorption. This increases blood calcium levels. Option A PCT reabsorbs the majority, but is not the primary regulated site. PTH has minimal direct effect there. Option C is involved in water reabsorption, not regulated calcium transport. Option D is not a major site for calcium reabsorption. Question 2. A patient presents with polyuria, polydipsia, and hypernatremia. A water deprivation test fails to concentrate the urine, but exogenous ADH administration does concentrate it. This indicates Option A. Central diabetes insipidus deficiency of ADH production. Option B. Nephrogenic diabetes insipidus renal resistance to ADH. Option C. Primary polydipsia psychogenic water drinking. Option D. Uncontrolled diabetes mellitus. The answer is A. This scenario describes a stepwise diagnostic approach for diabetes insipidus DI, which causes the inability to concentrate urine. 1 water deprivation test. The patient is deprived of water to stimulate maximal endogenous ADH release. If the kidneys can respond to ADH, urine should become concentrated high osmolality. Failure to concentrate indicates either a lack of ADH or kidney resistance to it. 2 exogenous ADH administration, synthetic ADH desmopressin, is given. If the kidneys now concentrate the urine, it proves they are capable of responding to ADH. Therefore, the problem must have been a lack of endogenous ADH. This is diagnostic for central neurogenic diabetes insipidus, where the hypothalamus or pituitary fails to produce/secrete adequate ADH. Option B, nephrogenic DI, would show no concentration even after exogenous ADH because the kidneys are resistant. Option C, primary polydipsia, would show normal concentration after water deprivation because ADH is present and kidneys work. Option D, diabetes mellitus, causes polyuria from osmotic diuresis due to glucosuria, but urine can be concentrated for other solutes, and it doesn't cause hypernatremia. It typically causes hyponatremia or normonatremia. Question 3. The BUN creatinine ratio can help differentiate causes of acute kidney injury AKI. A ratio 20:1 is most suggestive of Option A, intrinsic renal disease e.g., acute tubular necrosis. Option B, prerenal azotemia e.g., dehydration, heart failure where urea reabsorption is enhanced. Option C, postrenal obstruction. Option D, rhabdomyolysis. The answer is B. Blood urea nitrogen BUN and creatinine are both waste products filtered by the kidneys. In prerenal azotemia, reduced kidney perfusion without parenchymal damage, e.g., from dehydration, heart failure, hemorrhage, the glomerular filtration rate GFR falls, causing both BUN and creatinine to rise. However, BUN rises disproportionately more than creatinine. This is because in states of low flow, the kidney tries to conserve volume by reabsorbing more sodium and water in the proximal tubule. Urea is passively reabsorbed along with water in this segment, so its clearance decreases more than creatinine's creatinine is not reabsorbed. This leads to a BUN-CR ratio 20:1 normal is 10-15:1. In intrinsic renal disease like acute tubular necrosis ATN, the tubular damage impairs reabsorption, so urea reabsorption is not enhanced. Both BUN and creatinine rise proportionally, typically keeping the ratio 15:1. Option C, postrenal obstruction, can cause a high ratio but is usually identified by other signs e.g. anuria, hydronephrosis. Option D, rhabdomyolysis, releases large amounts of creatine converted to creatinine, which can raise creatinine disproportionately, potentially lowering the ratio. Question 4. The BOTUS primary buffer system in the extracellular fluid is the Option A, phosphate buffer system. Option B, protein buffer system, especially hemoglobin. Option C, bicarbonate carbonic acid system HCO/HCO. Option D, ammonia/ammonium system in the kidney. The answer is C. Buffers are solutions that resist changes in pH when acid or base is added. The bicarbonate carbonic acid system HCO/HCO is the most important buffer in the extracellular fluid ECF, which includes blood plasma and interstitial fluid. Its importance stems from 1. High concentration. Bicarbonate is present in relatively high amounts 24 milliequivalent/L in plasma. 2. Open system. It is an open buffer system because its components are regulated by the lungs and kidneys. CO, which forms HCO, is volatile and can be excreted by the lungs, and HCO can be regenerated or excreted by the kidneys. This allows for powerful and sustained buffering. The Henderson-Hasselbalch equation pH 6.1 log HCO/0.03 PaCO describes this system. Option A, the phosphate system HPO/HPO, is important intracellularly and in the urine, but is a minor buffer in the ECF due to low concentration. Option B, protein buffers, especially imidazole group of histidine in hemoglobin, are crucial inside cells like red blood cells and for buffering metabolic CO, but are not the primary ECF buffer. Option D is a renal mechanism for excreting acid, not a primary circulating buffer. Question 5. In the countercurrent exchange mechanism, the vasa recta maintain the medullary concentration gradient by Option A, actively pumping sodium into the interstitium. Option B, passively allowing diffusion of solutes and water along their gradients as blood flows slowly through the medulla, minimizing washout of the gradient. Option C, secreting urea into the collecting duct. Option D, constricting in response to angiotensin II. The answer is B. The countercurrent multiplier loop of Henle creates a hypertonic medulla. The blood vessels supplying the medulla, the vasa recta, must retrieve water and solutes without destroying this gradient. They do so via a countercurrent exchange mechanism. The vasa recta are hairpin-shaped capillaries that run parallel to the loops of Henle. Blood flows slowly down into the medulla and back up. As blood descends into the hypertonic medulla, water diffuses out of the capillary into the interstitium and solutes, NaCl, urea diffuse in, concentrating the blood. As blood ascends back toward the cortex, the opposite happens. It now contains higher solute concentration than the surrounding, slightly less concentrated interstitium, so solutes diffuse out and water diffuses in. This passive exchange along the entire length means that by the time blood leaves the medulla, it has picked up water and solutes, but the net removal of solute from the medulla is minimized. This preserves the osmotic gradient. Option A is the job of the thick ascending limb. Option C is a function of the collecting duct. Option D is a systemic regulatory mechanism, not specific to vasa recta function. Question 6. Fanconi syndrome is a disorder of the proximal tubule. What is the general defect and a common clinical manifestation? Option A, generalized dysfunction of all proximal reabsorption mechanisms, leading to glycosuria, aminoaciduria, phosphaturia, and type 2 RTA. Option B, isolated defect in water reabsorption, causing nephrogenic DI. Option C, defect in sodium-potassium exchange, causing hypokalemia and alkalosis. Option D, inability to secrete hydrogen ions, causing type 1 RTA. The answer is A. Fanconi syndrome is not a single disease, but a syndrome of generalized proximal tubular dysfunction. The proximal tubule normally reabsorbs a vast array of filtered substances: glucose, amino acids, phosphate, uric acid, bicarbonate, and low molecular weight proteins. In Fanconi syndrome, there is a defect in the transporters or energy supply for this reabsorption. This leads to excessive urinary loss of all these substances: glycosuria, sugar in urine despite normal blood glucose, aminoaciduria, phosphaturia causing hypophosphatemia and rickets/osteomalacia, uricosuriya, and bicarbonaturia. The loss of bicarbonate causes a proximal type 2 renal tubular acidosis RTA. It can be inherited, e.g., cystinosis, or acquired, e.g., from multiple myeloma, heavy metals. Option B describes nephrogenic diabetes insipidus, a defect in the collecting duct's response to ADH. Option C could describe the effect of some diuretics or Bartter syndrome. Option D describes distal type 1 RTA, where the collecting duct cannot secrete H effectively. Great job! Don't forget to subscribe. Bye!